Well, listen, everybody, thanks for joining. It's time for us to get started. This is a really casual session that we have every single week. It's affectionately called Third Thursdays, or sorry, Thursdays at 3, but the third one of every month. We talk about interventional glaucoma. And I see a lot of my interventional glaucoma colleagues and friends on the line here. As people join, we're going to make sure that we have an opportunity to have this be interactive. And I'll tell you the inspiration behind this session. As a recovering administrator, Ben still is one, but I'm fully in recovery. I ran Vance Thompson Vision for 20 years and have been away from there for a couple. And it seemed like with every new technology, there wasn't a good clearinghouse that would teach people how to implement it. There would be a lot of time spent on the sale, and then the doctors would bring in the machine or the widgets or the new lenses or what have you, but not a lot of time in developing the team members who are actually going to make it happen once the doctor went to the OR, the billers and the coders and the um, folks, who are implementing it. And so that's why we created this session is a clearinghouse to talk about operational engagement and how to implement these new technologies. Now, this one we're talking about interventional glaucoma. I'm here with my friend Ben Seals. And before we get too far into it, I'll just say this is a completely unsponsored session that we do for the good of the whole. I am a consultant, however, through my business life with the following companies. And I also want to just make a plug for a couple of the sessions that we've got coming up. And I think they're on the two most important topics in our field today. One is how to adopt premium at a greater level. We feel like at our company that a well-educated patient will choose a premium IOL if they have cataracts between 30 and 40% of the time. That's after working with hundreds of practices on their scripting and operations, no matter what market. We think that if left to no pre-education, practices will continue to adopt at about the national average of 12%. So we've created a whole course. Dr. Vance Thompson and others, including Ben and others on this call, have created curriculum that we take practices through. It's called the Business of Refractive Cataract Surgery. It's the first weekend in October. And there is a ton of information that's shared. People bring their forms, their financial consent forms, their medical informed consent, their brochures, and everybody shares and swaps and role plays how to have those conversations and hopefully to help increase adoption to premium by gaining confidence. The second session that I want to just mention here before we get started is the business of interventional glaucoma. Now, it's a really exciting time to be a part of glaucoma care, and I can't even imagine 20 years ago saying something like that. But because the disease is progressive, and because up until now, our mainline treatment was something like drops, which we know patients are not compliant with. Pick up any study. There's adverse events. It costs too much. A lot of them don't even fill their first scripts. And yet there's so many easy ways to do a first line treatment that can be billed to insurance. Um, but implementing it at the point of care with the busy practice can be difficult as well, and navigating those patients. It's what we're talking about today. There's a whole day course just before the academy in Orlando that we're having just on interventional glaucoma and the business side of it. So this is directed towards administrators as well, just like the BRICS course, along with their providers to figure out how to implement these new technologies at the point of care, what kind of scripting needs to be used, what kind of pre-education, pre-authorization, et cetera. So join us at those events. A lot of your colleagues and faculty, doctors from across the country who've done well at this will be in attendance and will be faculty to teach us on those things. Now, thanks. Thanks for letting me do some shameless plugs for our friends over at Askers and ASOA. They are who put on these courses. Now, I want to talk to you about Ben Seals. Ben and I have known each other for a few years now. I got to know him most when I wasn't actually an administrator anymore. And he, along with a couple of you on this call, are some of the best administrators I know of. I'm kind of a communications hack. I loved growing up, figuring out how to promote things, how to get teams to work in a dynamic fashion to facilitate change. But there are some very good and sharp administrators who run great practices, and Ben is one of them. Just because I'm on the line, I should probably say Casey's one of them, Patty's one of them, Melissa's one of them. A lot of you are people I've looked up to on the admin side of things. But he
I
runs
was about
really.
to say, Matt, like you're calling me out in a group of folks that I don't know it's fair to say what you're saying, but your thing is communication, so I get it.
Yeah, yeah. Well, listen. So, but he does a great job at leading a really diverse group, and he's done so for a few years. But I think the thing that's most remarkable, and especially as we're talking about IG today, he's taken a topic where, again, the marketplace is people with a progressive disease that are wildly unserved. Now, we think at the practice that they are being served because we gave them a prescription, sometimes more than one. But yet they haven't had a procedure that arrests the progression of the disease. And he's found a way through looking inside his own organization, looking at the data we already have, to reach out to patients and get them on a choreography into a plan of re-seeing them. And it doesn't take a big marketing communications plan. It takes some data mining, some coordination, and some good leadership. And that's why I'm excited to have you on the call today, Ben. So thanks for joining.
Absolutely. Thanks, Matt. I'm glad to be here.
And no, and thank you for your compliment back to me also. Thanks. Um, just kidding. Ben, I want to start with because there's a lot of folks here who are implementing IG in their practices or have helped other practices do it or want to. I want to just ask you, talk to me about how you drive IG success. Because a year ago, this you were just beginning to think about this, and since then you've made it a whole
Yeah.
kind of marquee offering in your practice.
Yeah. It's been one of the most successful programs that we've rolled out at Thomaside Group. And one of the reasons that I think it has been as successful as we've seen it turn within the practice is the alignment between our support from industry partners and the resources and the information that they're bringing to our practice and to our clinicians to help drive this change, the buy-in from our clinicians, and then the alignment with those physicians in industry with my operations team, clinical operations team, to help drive this change through our practice. So oftentimes there's a divergence in those. You'll have a sales rep who sells something to a doctor, but leaves out administration or neglects the communication and implementation plan with us as administrators. But what I have seen with IG and what we have experienced within Thomaside Group over the last, I would say really 12 months has been a coordinated collaboration between different folks throughout the industry, our doctors and their buy-in, and then ultimately as we rolled this out with a strong education and communication plan to our internal providers, to our referring providers, to the community, and then our patients at large, we're seeing some tremendous success from that. So it really is the coordination and collaboration of those teams working together that's allowed us to be successful.
Okay, so that's good. And that's a good like overview of the constituencies, right? But I'm talking to a doctor in Omaha a year ago, and they believe that they should maybe stop using drops as a first line therapy and start looking at things like the laser or procedural pharmaceuticals or even I mean there's even some MIGS procedures you can do without having failed another therapy. Like you don't have to fail drops in order to intervene in that fashion. And her thought is, I want to hang a billboard that says, "Stop the drops," or if you're on drops, you need
Yeah.
a second opinion. Was kind of her commentary. Bold, right? Because drops are, once an intervention has
So
taken place, drops can be a nice bridge between that and your next intervention. But rather than going out into the marketplace and starting to put gross rating points behind that message. Talk to me about going inside your organization and looking amongst your own patients in the database. Walk me through the step by step.
yep. So I don't think it's a secret that I'm a little bit of a data hound. And so when it comes to measuring and tracking information and then doing the research, I'm a little bit more comfortable in a spreadsheet than I am in clinic. That's just the reality of where I grew up. So one of the areas where we started is we actually did a data review, and there's Stephen Oliver's on the line. He actually worked with me directly where we pulled out some of the information related to our doctors and looked at, okay, how IG are we really? And so let's look back at a period of time where our doctors saw a specific segment of patients. Let's look at the glaucoma diagnoses for that particular patient set in a given month. And then let's fast forward 14 months and look at, did we actually do an IG, MIGS, or some sort of interventional procedure, or did we just see that patient 27 times? And so looking at that data and putting that in front of the doctors to show them, these are the subset of patients where you performed some sort of MIGS or interventional glaucoma procedure. These are the other patients where they're just coming in on a cadence and going through the scripting and getting their testing and getting their drops renewed. And so that initial evaluation gave us a benchmark where we could start to look at, okay, we know where our practice has been historically. Now, where do we want to affect the most change? And so we started in a number of different paths that we were running concurrently, but every single one of those was based on data. So we looked at where within our practice we saw the most glaucoma prescriptions and the most glaucoma diagnoses being written within our provider base. So at Thomas Eye Group is an integrated practice where we have 38 ODs within our organization. Most of our referrals for glaucoma consults and surgical care come from those 38 ODs. So I have the unique perspective of I can actually go look at the referring provider's behavior and understand whether or not the education, the training, the clinical protocols that we've rolled out in conjunction with, the study that was done by Dr. Funke and Dr. Micheletti and some others around how they would recommend interventional glaucoma be used as drops as a bridge to therapy versus drops as a management
You're talking
until
about
there's a more severe situation.
the consensus protocol that they developed?
Thank you for the name. I couldn't remember it off the top of my head, but yes,
No, no
that
worries.
protocol.
Yeah, that's worth mentioning just because
Um,
10 or 12 doctors got together, summer of 24, and in a retreat style, all kind of collaborated on, okay, OHT, mild, moderate, severe, refractory glaucoma. What's the order of escalation that we'll treat patients within each of those categories? What would we do first? And most doctors thought it couldn't be done to come up with that kind of protocol because there's so many things that are coming at you. And they all agreed that while that's true, there are some basic frameworks. And that's so helpful, as Ben just mentioned, when MDs are talking to ODs about like, here's basically how I treat my glaucoma patients. Here's the order of operations or the escalation plan. Having that consensus protocol is a great communication tool. And you use that
yeah.
then to talk your MDs to talk to your ODs, is what you're saying.
Yeah, and actually, I'll give credit to my two doctors. So we started this conversation about IG in October, and one of the things that I asked them for was a consensus on their protocol. And so they went through a process where those doctors together sat down. So Dr. Wallace and Dr. Garza internally at our group, and agreed upon a protocol for care. And it was a week after we ran our first OD education seminar that the consensus protocol came out, and it was exactly the same as what they came up with. So it was this really unique validation point of,
Yeah.
the protocol that they had built was actually what the leaders in our industry, some of those KOLs that were out there, were recommending for patients as we move forward. So it just enabled those doctors to feel more confident as they went in with their OD physicians and friends and referral
Yeah.
groups and even their colleagues, so MD to MD, to say, this is the protocol that we're asking you to follow as the glaucoma specialists. It actually matches with the protocol that's being published by this consensus group that got together to try to build this and help the community understand how to better generate care.
Okay, so you went back, you've got your MDs communicated with on what the current state is. They've communicated with the ODs within your program. And now it's time to actually do some implementation. And I'm going to feed you kind of what I'm hoping to hear from you on. You've got thousands and thousands, tens of thousands of patients in your database from over the years. And you use, I think, um, ModMed, is that right? And
That's correct.
And my guess is that you can tell whether or not patients are on a drop or have been diagnosed with ocular hypertension or whatever, but no treatment yet, no procedural intervention. And so then now you've got this list of our kind of, drops but not treated folks. Um, what do you do next?
Yeah. The first thing that we did is we ran a webinar and we said, like, hey, internal patients, you know these doctors, you know our group. Let's get on the phone and let's talk about how the options available to patients on drops has changed and the paradigm is shifting. And so we gave our doctors the opportunity to get on a webinar similar to this with our patients and just talk to them. And we saw a tremendous response to that. We had several hundred patients sign up for and watch that webinar. And out of that webinar, we saw a pretty significant spike in consult volume come through the practice in the 30 days following for the doctors that ran that webinar. The other thing that we do, and we're building this, right? So interventional glaucoma is something that is evolving, and I feel like there are some practices that are leaps and bounds ahead of me and Thomas Eye Group and our organization. My hope is just to share some of the things that we're actively working on. So one of the things that we did is we're actually measuring the new patients that come into the practice and receive a new prescription for glaucoma drops for the first time. And so if a patient comes in and sees one of our ODs or MDs inside of the practice for the first time, we have a small group that we're piloting this with, a group that has a strong rapport with our glaucoma doctors. We're actually having our glaucoma doctors have a one-on-one case review with the ODs to talk about, hey, you prescribed this patient a drop a month ago, but you didn't refer him for IG. Can we talk about why? Can we understand what the patient's response was? Did you educate? Did you have the materials in your hand where you felt comfortable referring to me? Was there a burden or a hindrance to that patient for them coming to me? Did you recommend it and the patient just didn't follow through? And so we have some logistics and process issues within the practice that aren't supporting you as the referring provider getting those patients to us in a timely manner. But ultimately, if we're all aligned on, and we selected the group of ODs that truly is aligned on, interventional glaucoma is the best chance for the best outcome for our patients. And so it's not all of our ODs that we're doing this with, it's a small subset, but we want to start small and have those peer-to-peer conversations around, okay, if we believe the data and the data shows that patients aren't compliant and patients on drops have a significantly different outcome, a high percentage of the time than patients who get intervention early, why are we not using drops as a bridge to intervention therapy and getting those patients into the chair of a doctor who can coach them, educate them, and teach them about intervention? So measuring the outcome that you want and then going back in the process a couple steps to say, okay, if this process is supposed to be fed by something upstream, let's measure upstream. And then let's find where it's deviating from that and what the fork in the road is, or sometimes there's multiple forks in the road, and where are we not creating pathways to success for our patients.
Okay.
So we're trying to chase that down right now. I'm excited about the data that it creates, the volume that's there.
Yeah, let's talk about that for a second.
What you put your patients through.
Let's talk about that, because the first time you did that report, I think you did a 3-month review, right? You wanted to see who, last 3 months, how many patients, I'm going to screw it up, but how many patients did we see that were on drops that haven't had an intervention or something like that, right? What you want to define the parameters and then give us the number.
So this is where we're in progress, right? So these numbers are not where these are real numbers, and you'll understand that comment completely. So Thomas Eye Group sees somewhere between 1,800 and 2,000 glaucoma patients per month. So in any given month, those are the unique patient counts that we have within our organization. Less than 200 of those patients are referred for an interventional glaucoma consult in any given month. So we're at about a 10% conversion rate across the patients that we have that have not received a interventional glaucoma procedure. So we discount those out. So about 25% of those 2,000 have already received an interventional glaucoma procedure, and they're just in their standard follow-up of care. But that leaves me somewhere between 1,500 and 7,500 or 1,700 potential patients to intervene with that we need to do education on. And so that's another reason why we picked a small subset, is that's a lot to go chase down. And we really wanted to start small and see if there's any common factors that we could find in the dialogues that our doctors are having between each other.
Well, I know we've got some people on the line who are into, marketing and communications, or working with the optometric network if it's outside of the organization. But with those kinds of numbers, I think of things like, okay, so in a world where LASIK is down, yet we've got a glaucoma program where we're wildly underserving our population. And that's a big thing for a non-doctor to say. So let me qualify that, okay? If we believe that patients are not adherent to their drops, and if we believe that they're not adherent because of the cost, or because there's side effects, or because they don't refill them or fill them in the first place, or they put them in wrong, and there's countless studies on this. So once a patient is diagnosed, to say that they're on drops and under management is to say that that's true of maybe 18 to 20% of them, but the rest of them are still kind of unmanaged because they're not taking their drops in a therapeutically viable fashion. So that 80%, they are good candidates for procedures that we can make their life better with, stop the progression, while still making them happy, maybe reducing their dependence on a drop. Meanwhile, profiting the practice, because a lot of these procedures can be pretty good, for reimbursement, amongst the likes of a cataract surgery or things like that. If you're talking procedural pharmaceuticals and MIGs and others, if you're talking about lasers, that's not quite as much, but it's also not that big of a burden on your program. It's pretty efficient.
And last I checked, they all pay more than we get paid for drops. So whether it's a laser or a MIGS procedure.
Yeah, that's a really important point too, isn't it? Not to mention all of the, it'd be interesting if we had one of your technicians on the call just to ask them, in a day, how many calls do you get about drops, clarifications, or scripts, or things like that? Because the burden on the practice is for real. Now, the other thing I want to say is, so let's say that you took that 3 months of patients that were anywhere from 1,500 to 750 or 1,750 a month. So let's just call it 4,500 low side, who might be candidates for a non-drop related intervention. Okay. How do you process them and get them into the program?
Yeah, so we're doing a couple different things, one of which is outreach. We're doing proactive outreach to a select group of patients that are coming out of that study. Another program that we're running internally is where we have doctors who are selected or have opted into this program. We run a campaign every week to scrub a doctor's schedule to see what patients are on their schedule next week that are taking drops and have not had an interventional procedure. And we're sending those patients a text message and an email in advance of their appointment, giving them some educational material related to why drops are so important. But if drops adherence is a challenge for them, if they're struggling, that there are other things that they could consider and should ask their doctor about. So we're pre-educating, and similar to how pharma prompts all of our patients to ask about drugs before they come in, when they're in the office with their doctor, we're asking patients to ask our doctors about the procedure, because what the feedback that I've received from my doctors is they're bought in, but changing the habit of their normal scripts that they go through with 30 or 40 patients doesn't always come naturally, and it's not easy. And so when a patient interrupts them and it's like, hey, before you refill my drop prescription, I saw that video that you sent me about procedural pharmaceutical or some other MIGS procedure or whatever. Can you give me more information about that? And then it stops and it interrupts the doctor or the technician in their flow and gives them the opportunity to provide the patient education about that.
What I'm hearing is some practices have gone to kind of a reallocation of their clinic spots, Ben, where because you're right, looking ahead at future patients, that's a no-brainer. We should make sure they're all pre-educated now about a procedure first approach if you want to be truly interventional. But with that bolus of past patients, getting them back in for a surgical intervention is really important because otherwise they're not going to come back up on your schedule for, months, maybe a year. And
Yep.
so some of these practices have created maybe an afternoon where they're just going to say, listen, we're going to, 4 weeks out from now, we're holding Thursday afternoon open. And that's just going to be IG related spots. And we're going to designate a
Mm.
person, much like in the old days when we used to have a refractive coordinator. We've got an IG coordinator, and they're going to go back and call some of these past IG patients who are candidates if they want to come back in and fill these spots. So then we've got an afternoon of just, see and do SLTs, or, meaning you see them in the clinic, they go right over to the laser, or pre-scheduled maybe, yeah, procedural pharmaceutical or what have you. And that way they start to get in their mind, wow, I can have, this whole bolus of surgical intervention where I'm just really, really grinding on those
Yeah.
past patients, while the rest of the schedule is kind of trying to catch up with that interventional mindset with the scripting and everything. What do you think about that?
I think I love the idea of segmenting it out, kind of like we do with our LASIK consults, where it's a dedicated section of the day so that those patients get the time and attention that they need, so that you're not intermixing them into the rest of normal clinic. I love that idea. I think one of the challenges that we see that really coincides with that thought process is the patients who have been on drops for a long time and may just be hearing about intervention for the first time. That's actually a longer and more time-intensive education process, because some of these patients may have family members who had had glaucoma, and drops was the only option for them for their entire life, and now they're on drops, and so they don't understand the new technology that's there or why it's just now being presented. And so really giving those patients the time and dedicated attention that they need for education is a huge part of making IG successful.
Yeah. Well, listen, I want to continue to, I think that's a good and the right response. Um, if I'm a practice looking to grow my surgical volume and I've got this set of patients over here who can benefit from it, like you, I want to push to get those folks pre-educated, and I'll reallocate people to do that pre-education before they come in, so we can get them to surgery, get them stabilized, and then get the next person in that chair because there's so many people from the past who we should be intervening
Yeah.
on. Plus, there's an insurmountable amount of people out in front of us who need intervention too. We just
Yeah.
can't possibly get to them all. And so I do think this is a topic for
Yep.
the future, just because I want to be timely and make sure we have a few minutes for our Q&A, because usually there's a lot more chatter so far, but you and I have been good at our own chatter. Give us one pearl. If somebody on the line is, okay, I'm going to start this today, what should I do? What's the first step?
Yeah, I think it's I'm going to go back to data. It's set an expectation for what you want to measure. If it's outcome oriented, how many IG procedures are you doing this month versus last year, same month? And then start working one step back in the process. Okay, why do I have so many IG consults, but I'm not seeing, what's my adoption rate and completion rate on those consults to a procedure? What's that lag? Think about, one of the things that the community's really challenged me to do is to think about IG in the same way that we think about cataract surgery. What's our conversion rate? What's the lag time between consult to surgery? What is my adoption rate? Who are my best counselors? What are they doing well? And find those, look inside of your own organization. And leverage folks like Casey Gant and Melissa and Chuck and his team. Like, there are some folks that are doing some incredible stuff. Listen to them as well. I just know how to measure it and write the code to pull the data. There's some really incredible folks doing great things with IG on this call.
Well, and I'm ashamed that I didn't even notice you there, Chuck. Here, I was talking about all the Titan administrators here, and you're sitting right there. You're another one of them. Sorry about that. But Ben, the other thing I'm glad that you mentioned cataracts because a lot of things I used to hear in the cataract world is, listen, we'll see you in a couple months. We're just going to wait for your cataracts to get ripe. Right. And I feel like we're doing the same thing with glaucoma right now. We're gonna put you on drops for a little bit. See if we can like what are we waiting for? We've got something that will
Yeah.
guarantee that they've been intervened upon in a surgical fashion, rather than cross our fingers about compliance. So, listen, everybody, this is a chance to unmute. I'd love your thoughts and questions for Ben, or for me. We can play a little stump the chump and ask Ben. Um, I'll be the chump. Trisha, Chuck, Melissa's, give us a question.
Yeah, I've got a question, Ben, and great talk, you guys. This is phenomenal. How I just wanted to ask, how have you engaged your marketing team or engaged in messaging patients prior to their visits with their doctors about their options? Have you been able to send those patients that are inbound to your doctors messages of their options for interventional procedures?
Yeah, great question. So we use, in conjunction with ModMed, we use a tool called RSI to engage with those patients. And if it's a glaucoma consult, they get a specific script of information related to, they get a letter from the doctor explaining what interventional glaucoma is, because likely they're already on drops and that's a bridge to a procedural therapy. They get an explanation of what to expect on their day of clinic. And then that information has links to video education material that we've curated internally that talk to the patient about MIGS, talk to the patient about SLT, talk to the patient about procedural pharmaceuticals, all of their different options so that they can get an understanding of, what is this scary disease that doesn't have to be as scary as it used to be, why they're coming to see a specialist, and what their options are that they'll be talking to the doctor about the day that they get to surgery or the day that they get to the consult.
That's awesome.
Any other questions coming from the group or points of discussion? Patty, I like your haircut.
Well, thank you. I will say we see a lot of glaucoma, and we in Jacksonville tend to get very, very serious cases as well. And I do think everybody has to keep in mind that not everybody is a candidate for interventional. There are some 0.8 cups out there, and they have very little vision left, and it's all we can do to preserve it. And we do have to be careful that we don't send mixed signals to those types of patients, because they need their drops and they need their surgery. They need a lot of stuff to keep that vision for themselves.
You're absolutely right.
Hi, Ben. This is Melissa. I'm curious, as
Hey,
you've
Melissa.
rolled this out, what has been kind of the biggest obstacle or what you've kind of maybe come up against and how you've overcome that? If it's belief, is it changing patterns? Is it getting the team on board? Is it communicating with the doctors who are referring their patients in? Just looking for some insights there.
Yeah, so we thought that it was going to be the referral doctors and resistance from them, and which is why when we started rolling this program out, we started with them first and had direct conversations in small environments with them about why the treatment paradigm is changing. And the feedback that we got from the referring providers is very similar to our practices. As much as we hate to manage patients' prescriptions and the administrative burden that puts on our practice, the referring providers don't really enjoy it either. And all of the work that they have to go through to get prior auths done and flip scripts and move pharmacies and refills and all of that. So the referring providers were quick to pick up on this. What I found has been the biggest challenge is changing the talk tracks in the lane with in front of the patient to not be so focused on drops plus follow-up plus testing equals good outcomes for glaucoma. This is the best option for you, a direct recommendation. And there's some great information that some of the doctors in our community have put out. There was an article from Glaucoma Today. It was a video from ASCRS from some of the titans in glaucoma about we have to get better at making direct recommendations to patients. I think that's what our patients are looking for. They come to our doctors because our doctors are experts. And when a doctor gives a qualified recommendation, a patient is less confident in making that decision for themselves. And so I would say that the resistance that I expected was not where I found it. The challenge has been reworking the scripting and the education in the lane with that patient so that they're confident in what's being recommended to them.
Yeah, changing that script. I mean, doctor behavior is hard to change, as we know. And I mean, so is ours, by the way. But once you get in kind of a rhythm, it's very difficult. And now I want to challenge you, Ben. You said, current paradigm is drops plus time plus follow-up plus diagnostic plus drops plus time equals, doing our best, our best outcome for glaucoma, or however you said it. What's the alternative? What should it be?
Yeah, it's drops plus intervention equals better outcomes and better compliance and less lost vision. That's what the LIFE trial shows. Like if you intervene,
and that's where all
in a significant way.
This is the thing, and this is something for us all to keep in mind. A lot of you on this call, you are at the very, very forefront of this category. And even the way you said it, Ben, you said drops plus intervention plus whatever equals, right? And I think until we start to say intervention, drops as a bridge, follow-up diagnostic to the next intervention, drops as a bridge. But I think we have to start with we have to stop the progression. And I know it's a small thing, Ben. So thanks for letting me like trip.
No, but it prevents that patient from getting to Patty's clinic with the cup that she cited and the vision loss that they have. Is if you intervene now, 20 years from now, they'll have the vision that they need to live the life they want to live. And if we don't intervene now.
Yeah. So listen, this is a great discussion, everybody, and I love the questions, and we can take a bunch more of these offline. We're having sessions like this every week, and I feel like they're very helpful. I wish they would have been around when I was trying to be an administrator, but I'm really grateful that all of you, some of you, my mentors, all of you, my friends, are on the line. Next week, we're talking about a complicated topic as well. It's the light adjustable lens and the MD-OD partnership. And my friend, Dr. Nick Bruns, he does just a ton of light adjustments for the LAL, works with Dr. John Vukic in Wisconsin, and really has a lot to say about the verbal anesthesia that's used with patients, about talking about expectations. What can you count on? What shouldn't you count on? Here's how to go around, over the next couple of weeks as you're waiting for your next adjustment. Here's what to use your vision on, and then how to do that in a collaborative MD-OD environment. I think it's going to be a really rich conversation. We already have 30 folks signed up for that one, so tell your colleagues and friends to join us next week. And then you can go to our website and see the rest of the schedule through the month of September. We're excited about those conversations as well. But Ben, you know how to draw a crowd, my friend. Thanks for joining us, and everybody else, thanks for joining too.